Hi, welcome to EDSC 541 Psychopathology. This is week 4. This week you have just 2 discussion boards due for your assignment for the week. And I'm going to briefly go over some important factors from the chapters 7 and 8. So chapter 7 focused on mood disorders and suicide, and chapter 8 focused on schizophrenia. So mostly it talked about the people with depressive disorders, that they experience only the symptoms of depression, sadness, mood, loss of interest, disruption in sleep and appetite, motor retardation or agility, loss of energy, feelings of worthlessness and guilt, suicidal thoughts and behavior. People with bipolar disorder experience symptoms of both the depression and the hypomania or mania, which is elated or agitation mood, grandiosity, little need for sleep, racing thoughts, and speech increased in goals and dangerous behavior. The some other things, any presence of one or more of the hypomania or manic episodes is the core feature of the bipolar disorders. So the major depressive disorder is the classic condition among the depressive disorders. It is characterized by discrete episodes of depression, mood, and or loss of interest or pleasure or other symptoms that last at least 2 weeks. In addition, there are several subtypes of major depressive disorders with mixed features of anxiety features, with melancholy features, with psychotic features, with catatonic features, with atypical features, with seasonal patterns, and with peripartum onset. All right. So persistent depressive disorder is a chronic form of depression that continues for at least 2 years in adults or 1 year in youth. It can be less severe than major depressive disorder, and the full criteria are not met if the full criteria is not met in the last 2 years, or may be represented intermittently, or it can persist major depressive episodes, and it can also include many of the same subtypes as the major depressive disorder. So now, premenstrual dysphoria disorder is diagnosed when women show an increase in symptoms of distress in the weeks before the onset of menses, with relief of the symptoms after menses begins. And then the cyclothymic disorder is a less severe but more chronic form of bipolar 2 that does not include the major depressive disorders. So depression is one of the most common disorders, but there are some substantial age, gender, and cross-cultural differences in depression. Bipolar disorder is much less common than the depressive disorders, and it tends to be a lifelong problem. The length of the individual's episode of bipolar, as in depression, varies dramatically from one person to the next and over the course of a lifetime. So our neurotransmitters play a role in all of this. We have our norepinephrine, the serotonin, the dopamine that have been implicated in the mood disorders. Disordered genes may lead to dysfunction in these neurotransmitting systems. And also the neuroimaging studies show that abnormal structure and activity in several areas of the brain, including the prefrontal cortex, the hippocampus, the anterior cingulate, and the amygdala. There's evidence that people with depression have chronic hyperactivity in the hypothalamic pituitary adrenaline axis, which is the HPA, which may also make them more susceptible to stress, right? Some behavioral theories of depression suggest that people with much stress in their lives, may have too low a rate of reinforcement and too high a rate of punishment, leading to depression. Stressful events can also lead to learned helplessness and the belief that nothing you do can control your environment, which is also linked to depression. The cognitive theories argue that depressed people have negative views of themselves, the world, and the future, and engage in these biased thinking, and that promotes the negativity. And people who ruminate in response to distress are more prone to depression. Interpersonal theories, they suggest that people prone to depression are highly sensitive to rejection and engage in excessive reassurance seeking, and levels of interpersonal stress and conflicts are high in the lives of those depressed people. Sociocultural theorists have tried to explain differences in rates of depression among different demographic groups, and the decreased risk of depression in older adults may be due to historical cohort effects, and women are at a greater risk for depression. It may be due to differences in the way that women and men respond to distress, and women's greater interpersonal orientation, and lesser power and status, and higher rates of victimization. So high rates of depression in Hispanic Americans may be due to low socioeconomic status. Bipolar disorder has even a greater connection to genetic factors than does depression. The areas of the brain most implicated in bipolar disorder are the amygdala, the prefrontal cortex, and the striatum. Adolescents with bipolar disorder show abnormalities in white matter tissue. Dopamine is the neurotransmitter most implicated in the bipolar disorder, and people with bipolar disorder may have a dysfunctional reward system. They are hypersensitive to rewards when in manic states and insensitive to rewards when they are in a depressed state. So most of the biological therapies for mood disorder are drug therapies, which include antidepressants and mood stabilizers. The electroconvulsive therapy is used to treat severe depression that does not respond to drugs. Newer methods of stimulating the brain include repetitive transcranial magnetic stimulating, TMS, the vagus nerve stimulation, and the deep brain stimulation. It holds promises for treatment of mood disorder. Light therapy is helpful in treating major depressive disorder with seasonal patterns. Behavioral therapies focus on increased positive reinforcers and decrease negative events by building social skills and teaching clients how to engage in pleasant activities and coping with their moods. Cognitive behavioral therapies help people with depression, and they develop more adaptive ways of thinking. And interpersonal therapies help people with depression and identify the changes in patterns in their relationships. Interpersonal social rhythm therapy helps people with their bipolar disorder and manage their social relationships and daily rhythms to try to prevent a relapse. And family-focused therapy helps people with bipolar disorder to manage their disorders. Direct comparison of various psychotherapies and drug therapies show that they tend to be equally effective in treating depression. And psychotherapies may be more effective than the drug therapies in reduced relapse. Suicide is defined as a death from injury, poisoning, or suffocation when there is evidence, either explicit or implicit, that the injury was self-inflicted and that the decedent intended to kill him or herself. Women are more likely than men to attempt suicide. Cross-cultural differences in suicidal rates may have to do with religious proscription stress and stressors and cultural norms about suicide. Young people are less likely than adults to commit suicide, but suicidal rates among youth have been fluctuating dramatically in recent decades. The elderly, particularly elderly men, are at high rate for suicide. Several mental disorders, including depression, bipolar disorder, substance abuse, schizophrenia, and anxiety disorder, increase the risk for suicide. And there are several negative life events or circumstances, including economic hardship, serious illness, loss, abuse, increase the risk for suicide. Suicide clusters, also called suicide contagion, they occur when two or more suicides are attempted and are non-randomly bunched together in a place or time. Impulsivity and hopelessness are predicted suicidal behaviors. Family history, such as twins and adoptive studies, all suggest genetic vulnerability to suicide, and many student studies have found a link between low serotonin levels and suicide. Drug treatments for suicidal patients most often involve lithium or antidepressant medication. Psychotherapies for suicide are similar to those for depression. And dialectic behavior therapy addresses skills deficits and thinking patterns in people who are recurrently suicidal. Suicide hotlines and crisis intervention programs provide immediate help to people who are highly suicidal. And community prevention programs aim to educate and to encourage suicidal people to enter into treatment. Guns are involved in the majority of the suicide, and some research suggests that restricting access to guns can reduce the number of suicide attempts. So in chapter 8, we talked about schizophrenia and the spectrum and other psychotic disorders. So some important information from that chapter was that there were 5 domains of symptoms that define psychotic disorders. They include positive and negative symptoms. Those positive symptoms of schizophrenia include delusion, fixed beliefs that are held strongly despite conflicting evidence, hallucinations, unreal perceptions, experiences, thought disturbances, incoherent thought and speech, and grossly disorganized and catatonic behaviors. The negative symptoms of the schizophrenia include restricted effect on evaluation, the inability to initiate and persist in goal-oriented activities, separation, prodromal, and residual symptoms that are mild versions of the positive and negative symptoms that occur before and after an episode of an acute symptom. Cognitive deficits in schizophrenia include problems in attention, working memory, processing speed, learning and memory abstraction, and problem solving. The estimates of prevalence of schizophrenia varies from country to country. It ranges from about 0.1 to 2%, but most estimates are between 0.5 and 1%. There are some slight ethnic differences in rates of schizophrenia, but these may be due to differences in socioeconomic status. The content of delusion and hallucinations vary in schizophrenia and somewhat across cultures, but for the forms of these symptoms that remain similar, many clinicians and researchers believe that schizophrenia can be diagnosed reliably across cultures. A number of other psychotic disorders are recognized by the DSM-5. The schizoaffective disorder is diagnosed with symptoms of schizophrenia with periods of major depressive or mania. Individuals with the schizophreniform disorder meet the criteria for schizophrenia, but for a period of only 1 to 6 months. Those with brief psychotic disorders meet the criteria for schizophrenia, but for a period of less than 1 month, and sometimes in response to major stressors. Delusional disorders is characterized by one kind of psychotic symptom, which is delusions. And schizotypical personality disorder is characterized by lifelong patterns of severe oddities in thought, behavior, and self-concept that fall short of psychosis. The biological theories of this schizophrenia focuses on genetic, structural, and functional abnormalities in the brain and neurotransmitters. There's clear evidence that the genetic transmitters of schizophrenia, but people with schizophrenia show abnormal functioning in the cortical areas of the brain, particularly the prefrontal area and the hippocampus, as well as enlarged ventricles. Many people with schizophrenia have a history of prenatal difficulties, such as exposure to influenza virus during the second trimester of gestation, or birth complications, including prenatal hypoxia. Brain abnormalities and dysfunctions in the dopamine system play a role in schizophrenia, and stressful events probably cannot cause schizophrenia in people who lack vulnerability in the disorder, but they may trigger new episodes of psychosis in people with the disorder. Expressed emotion theorists argue that some of the families of people with schizophrenia are simultaneously overprotective and hostile, and that is the this increases the risk of relapse. Cognitive theorists suggest that some psycho symptoms are attempts by the individual to understand and manage cognitive deficits. Drugs known as, in the 50s, brought relief to many of the people with schizophrenia. Different types of drugs reduce the positive symptoms of schizophrenia, but often are not effective in reducing the negative symptoms. Major side effects included dyskinesia, irreversible neurological disorder characterized by involuntary movements of the tongue, face, mouth, and jaw, and atypical antipsychotics, most of which were introduced in the past 2 decades, seem to induce fewer side effects and are effective in treating both the positive and the negative symptoms of schizophrenia for many people. But still today, many people with schizophrenia do not respond or respond only partially to these drugs. Psychological and social treatments focus on helping people with schizophrenia reduce stress and improve family interactions, learn social skills, manage their illnesses, and cope with the impacts of disorders on their lives. Comprehensive treatment programs combine drug therapy and with an array of psychological and social treatments and have been shown to reduce relapses significantly. So our role as a school counselor is to know about all of these different types of disorders, as we may see some of our students being diagnosed with some of these mental mood disorders, suicidal tendencies, and schizophrenia. And our role is to see what's, combined with their psychiatrist, how can we help them to be more functional and be able to access the curriculum while in school. So that is our main role. All right, so don't forget you have your 2 discussion boards due for this week 4, and I will see you week 5 live on session online.